My name is Michael Iseman. I'm a professor of medicine at the University of Colorado School of Medicine in Denver. I'm the former chief of the tuberculosis program at the National Jewish Medical Research Center in Denver. I've worked in tuberculosis effectively since an intern at Bellevue Hospital in 1965, so I've got a few decades into the fray. I think young students of medicine go through the buffet of clinical experience and decide at some point that they kind of like that stuff in a yellow bowl or whatever. And for me, I was exposed to the TB ward at Bellevue. I did research as a fellow working with Julia Jones and Gladys Hobby. And then I went off to do 10 years of being an intensivist, ICU, bronchoscopy, typical pulmonologist. But one afternoon a week I did the TB clinic. At some point I looked up, did an inventory and said the best day of the week is my TB clinic. And I had a chance to move over to National Jewish and head up the TB program then. It was 1982. It was not particularly a good time for TB. Nobody was paying much attention to it. But it just really interested me, and I found it then, and I find it now really my life's work. TB is a diabolically clever, good, smart, wise, crafty pathogen. It has been very successful in eluding human immunity. Like the other major infection that's plaguing the world today, HIV, it has defied effective vaccines, and without vaccines we really struggle to control an infection. It requires 6 months or more of therapy. It tests human tolerance and patience, and it is a really extraordinary, I think of it as both a scientific and a humanitarian and a humanistic challenge. We have gone about as far with the available drugs as we can go. We've done a series of studies to see how short a duration of treatment can be curative. And so we know that if we could reduce the duration of treatment from 6 months to less, we'd have fewer problems with non-compliance, drug resistance. But we can't get much lower. It's like limbo. We've gone as low as we can go. And so we need new medicines that will do two things: allow us to compress the duration of treatment and replace the medicines that have been lost globally to drug resistance. Right now, tuberculosis is receding as a problem in the United States. We are at the end of a very successful 15-year chapter of public health where we reduced the number of TB cases, the rate of TB, we've reduced drug-resistant cases, so we can celebrate here in the United States about the successes we've had. Selfishly, we recognize now that over half our new cases come from abroad, and that many of the drug-resistant cases that we continue to see are from abroad. So from a selfish point of view, we need to work abroad to make our own country safer. But in a global humanitarian way, we see that this is a disease that is going to ravage parts of the world. I'm worried greatly about sub-Saharan Africa, the parts of China, parts of India that are simply going to be crippled. One of the things about TB that makes it such a socially and economically devastating disease is that it leaves individuals sick, chronically ill, dependent on others, deriving of the treatment assets, and infecting others as they struggle along their last days and months. So it is, if we expect to see a more prosperous world in which family structures are retained, young people are taught to work and are educated, we can't allow TB to continue to devastate the developing nations. There's a very interesting struggle right now to justify developing new anti-infectives. I understand that. I think the world is driven by economic considerations, and certainly looking at the business model of anti-infectives, it may be problematic. It would seem attractive because you're using 4 drugs for up to 6 months, and so that sounds like a good business model. There are a couple of problems, however. One of them has to do with failure to acknowledge intellectual property rights. One of the things that I think discourages Western pharmas from getting into the business is the practice of, if you will, pirating drugs. And we have to confront this. Either there has to be some compensation, or else farmers aren't going to spend $350 to $500 million to bring a new product to market, only to have it taken away from them before they can recoup their expenses. I think there's really been very beneficial results when if a farmer gets to a certain point with an anti-infective, if another agency will take it over, do the heavy lifting of getting it studied and going through the evaluation that would allow it to be licensed. Those are important things that can be done. So I think a public-private amalgam is probably the way to move forward. What can the public do to help is a very difficult question. You cannot go home and open your mailbox and not see 3 or 4 letters there that are from not just some cause, but for needy and worthy causes. Probably your phone rings 2 or 3 times a night or more, again, worthy causes. So I think we really have donor or interest fatigue with all of the unmet needs in our society and in our world. It usually will take somebody who has a particular fascination. Somebody in their family died. They traveled somewhere and saw people lying on the street dying of consumption, something that moves them to do more than just feel a heavy heart and maybe put $1 in a basket. It requires committed people. So I think we have to keep making our appeal, and it's like selling any commodity. Not everyone will buy. You'll find some who are interested in the cause, that find the history, the extraordinary linkage to the arts. For me, one of the extraordinary things about tuberculosis is the way it's woven into opera and art and poetry, and so someone will be moved some way to say this is a disease that I want to support the eradication of.